So we're going to talk through some cases, and we've got Julian, who knows lots of wonderful things about medications and lots of wonderful things about psychiatry in general, and Tamara, who's pretty damn good at all the psychotherapy side of things and CBT and all kinds of exciting things. So we'll talk through the cases as we go, and please do ask questions. That's what we're here for, and it will be a lot more interesting if you guys jump in and ask your questions as we go. And I know we've got well, of all the people that have registered who's here tonight, we've got quite a mix of people, and I'd be very interested in hearing about some of your experiences in treating depression and things that you find difficult. I know the things that I find difficult are the messy things, the things where there's drugs and alcohol, the things where there are complex medical issues, the things where they don't do the things that we think they ought to do and respond to medication and talking therapies and all of the other things that make it complicated. So we've got some nice complicated cases for you tonight. So let's see how we go with those. And Julian, if you want to throw to our first case presentation. And this is a lady who is in her 50s and has a daughter who's in her 20s. When I say she's single, she's been without a partner for a long time because her partner left when her daughter was very young, about 4, I think, from memory. She works as a project officer and as a musician, and she's one of my patients, of course. And she's got a long-standing history of alcohol dependence, and particularly using alcohol excessively in social situations. But also, and this always worries me, when she was home alone, drinking quite heavily. And when she drinks, she does silly things and she becomes quite suicidal, and there have been a number of suicide attempts when her daughter was quite young. I remember talking about that with her daughter because I treat both of them. In the last 15 years when I first met her, and that was about 7 years ago, I think, from memory. She just moved down from the country. She was referred to me by her previous GP. And at that stage, she was taking venlafaxine, 30 milligrams, quetiapine, 25 milligrams as needed, and oxazepam, 7.5 milligrams as needed. Julian, while we're on the subject of venlafaxine, talk to me about doses of venlafaxine, because it's an interesting drug. Yes.
So venlafaxine is not quite unique, but reasonably unique in terms of antidepressants, in that there's a very clear dose-response curve when we're thinking about its efficacy in treating depression. And that might have something to do with its mechanism of action changing depending on the dose. So at or below 150 milligrams, it's predominantly serotonergic. So in many ways, probably no different to most SSRIs like citalopram or sertraline. But at least theoretically above that dose, so 225 and above, it has more of a noradrenergic action. So there's some evidence that it has an edge over many other antidepressants in the treatment of very severe depression, particularly with melancholic features. And as I was saying before, there is evidence that the higher the dose, the more effective it is. But in terms of tolerability, it does tail off the higher you go, as you would expect. One of the major concerns with venlafaxine at higher doses is hypertension. And that's something that has to be always borne in mind. But in my clinical experience, rather than being overdosed, it tends to be underdosed. So it's not uncommon for people to have not been tried on the higher dose range, the more noradrenergic dose range that I was talking about before. And particularly in severe depression or people who've been chronically ill, I think it's worth trying the high dose range.
Yes, I've seen it in doses up to 450 milligrams. Yeah. And I'm also interested in the context, because the other lady that I've seen it in, well, a couple of people, but the other lady that I look after who's on 450 milligrams also uses alcohol. Is there any kind of issue with Because alcohol and antidepressants go together quite often, don't they?
Yeah, I think it's certainly something that people worry about and get told at the pharmacy, and is often on the box of medications. You know, do not drink if you're on this medication. The reality is that people do drink whilst they're taking antidepressants. In a safety sense, I'm much less concerned about people, having the odd drink on antidepressants compared to, drinking on other medications, sedating medications, basically. So, your antipsychotics and benzos. I guess what might be a broader issue to consider is whether they're drinking to the point that the antidepressant's not effective, rather than any kind of specific interaction between the two.
That's an interesting point. When you say that they're drinking to the point where the antidepressant isn't effective, are you talking about an issue with the alcohol affecting the efficacy of the medication, or are you more talking about the effect of the alcohol on the depression per se?
Well, I think both, and there's pretty clear evidence that antidepressants are less effective in individuals with depression and alcohol use disorder compared to people with depression in the absence of comorbidity. Having said that, sometimes the results of antidepressant treatment in alcohol dependence can be pleasantly surprising. On the other hand, I think it's very important before you start an antidepressant in someone who has alcohol use disorder to be very clear about what the expectations are.
Yeah, thank you. Tamara, do you get to work with many people with alcohol issues? Yeah, I thought you might.
I mean, look, it's common, and it helps that I'm actually at the Adelaide Clinic where they do the detox.
Oh yes, of course you are. Yes, that's right. Yes.
So yes, no, much more frequently than you think, and I would agree. My probably biggest sadness with it is that if you drink, it almost creates that pattern whereby you're naturally sleeping in, you're less active, stimuli to the brain is less. And as a result of all of just those things alone, let alone any other reason for drinking, that then causes depression in and of itself. There's also a lot of impacts of alcohol on sleep that's not necessarily known. So you get that a lot more dreaming, the REM, sleep rebound, and nightmares. So quite frequently, those who have an alcohol issue will have had a trauma, which will come out a lot more through that REM sleep rebound, which will then cause more drinking. So there's a lot of circular causes with that, and that I think that aren't necessarily understood, because people will say, well, it'll stop me from having those thoughts and it will knock me out and I will get to sleep. So there's a lot of those misconceptions.
It's a difficult conversation to have a lot of the time. The idea, people raise that they drink because they're depressed rather than, the other way around. And it can require repeated conversations around that, reframed in a variety of ways to make the point.
Yes, and it's ironic, isn't it, that I think what you were saying is that when people drink, the nightmares from the trauma tend to get worse, and so then they try and drink more to squash the nightmares. And it's never going to work, is it?
No, they're just going to get more and more rebound. It's the exact opposite effect that they're looking to achieve. So and can be more traumatizing.
Yes.
So
yes, exactly. Do you ever tell them that?
Yes.
And does that help?
They without fail almost never knew. So they did.
Yes.
It seems to be rare for people to explain that alcohol suppresses that dreaming, and then therefore there is a rebound later. So it's the sleep patterns and alcohol, just even the general population. So who have a couple of glasses of wine before bed don't necessarily know that they will then have much lighter sleep and feel much less refreshed in the morning. So a really early psychoed that's not frequently known.
Yeah, and I think as GPs, we are so well placed to have that conversation, because it's one of the things we should be asking about when people are depressed and suicidal. It sometimes doesn't get asked about, and we'll talk about a case presentation a bit later on where it did get asked about, which I thought was very interesting. But it's something where we've got an amazing opportunity to educate people. And just saying, you shouldn't drink, it's bad for you, doesn't work very well in my experience. Same for you? Yeah, exactly.
And Australian culture.
Oh, absolutely, and Australian culture, and especially when you're dealing with teenagers who go out, or young people, I should say, who go out and get hammered every Friday and Saturday night. But yeah, with these particular, and I find a lot of women in this kind of age group, it's quite silent drinking. Yeah, exactly. So yes, coming back to Our Lady, and she'd taken, I think it was a couple of overdoses, and one sort of fairly kind of, fairly ambivalent kind of overdose. Just, yes, thank you, Julian. Yes, I thought you might nod to that one. Talk to me about ambivalent overdoses, because there's still overdoses, aren't there?
They are, and obviously significant harm can result even if someone's not intending to do serious harm. So there's still a significant risk of misadventure. But going back to my previous job as a consultation liaison psychiatrist, so seeing a lot of people in the emergency department, the vast majority of people who come in with overdoses, or really any kind of suicide attempt, the vast majority of people are ambivalent to some degree, and it might require time spent with them to explore kind of deeper levels of ambivalence, and that can be very much a way in therapeutically in terms of addressing the crisis situation. But yeah, when you mentioned ambivalence, I just remembered how it struck me when I was working in emergency departments that the vast majority of people who attempt suicide are profoundly ambivalent about what they're doing.
I think that's exactly right. It takes me back to 30 years ago when I did a year of psychiatry training, and absolutely doing consultation liaison, and yes, I can absolutely remember that very clearly. And I think the trap for young players is that people can see that as people being manipulative. Yes. And Tamara, is that your experience too?
Yeah, I think there's a lot of misconceptions around why people make an attempt. Most of the time I find people are saying, I just didn't want to, I didn't know what else to do, and I wanted to escape the way I felt. And I think, if you think about it on a biological level, and there is no problem solving that's going to make a feeling that exists within you go away. One of the, most logical conclusions is to make an attempt. That if I could get this to stop, if I could just get the brain to shut off, I won't have to feel this. And I think it's there when people say, I just wanted to go to sleep and not wake up.
And coming back to alcohol, I would say the vast majority of overdoses that I saw during my time working in emergency departments involved alcohol in some way. Often, people started drinking, and in the context of drinking, ruminations began. There was an acute kind of lowering of their mood, and a degree of behavioural disinhibition as well. So overdose very often start with alcohol and then progress to other things. I would say roughly 80% of people that I saw with an overdose had some alcohol at some point. In the period of time, prior to overdosing or drink.
Yeah, that's certainly a very common thing that I tend to see as well. Yeah, exactly. And I'm thinking in particular, I can't actually remember if I've included her in the case presentations, but of a young woman that I'm looking after at the moment who has just been released from hospital after 2 overdoses in fairly quick succession. And exactly that, both times, well, all the time she's overdosed, it's always been associated with alcohol. Yeah. Exactly. Yeah, it's a bad combination, isn't it? Yeah.
Particularly in people who already have difficulties with impulse control. So people with personality issues, trauma, brain injury, organic brain issues. Yeah, exactly. So yes, and this lady is fairly typical, looking at what she overdosed on, it was probably what she could get her hands on at the time. I must say the valerian was probably, she didn't even realise what she was taking. A strong chance. Yeah, exactly. And not surprisingly, there's a family history of alcohol dependence, so she's had some modelling as she's growing up, but she's also got a family history of death by suicide.
in that her grandfather suicided when her father was 10. So that's quite a young age to lose a parent, isn't it? Tamara, talk to me about what it's like for a child, because I mean, this is a transgenerational thing, obviously, but what it would have been like for that 10-year-old boy.
So, look, almost all of your identity is forming around those ages. So, to lose a significant parental figure at that time, especially if it's same-sex parent, so the one that you identify with the most, you're essentially having your entire identity questioned. You feel very alone, very lost, and without the guidance that you would normally have with a person to go to rely on. And I think, you know, two parents often provide that stability. And so the fact that, you know, he's lost his father at such a young age, same-sex parent, it would have been incredibly confronting. I would imagine that would also be something you'd be looking to avoid, squash feelings of, and alcohol does that really well, for at least the short term. And, you know, I'm guessing that she then saw that pattern of behaviour where, you know, we do know that what your parents do with drinking often becomes quite well modelled, and you tend to follow it. So she may well have learned avoidance of feelings, not approaching things, grief and loss as well.
And I think modelling is critical, but also some forms of alcohol dependence are highly heritable conditions from a genetic point of view, and that's been well established by twin adoption studies. And I can't remember the percentages off the top of my head in terms of the actual variability, but this is a fairly common picture that I would see clinically of a parent with alcohol dependence with a child who starts drinking at a very early age, so we're looking at 14, and describing exactly that, what you've written on the slide, so never having control. I often find in the people who start early and have that clear family history that they can very clearly describe not having control. And it's like as soon as they start drinking, the switch is jammed and they can't turn it off. Yeah.
That's exactly, and I have another lady that I don't know, again, I haven't brought her into this one, but another lady who was working with a psychologist at one stage because they decided that the second drink, she drank the first drink, the second drink kind of maintained it, and then after that it just was all over red.
That's right.
Yeah, so she was chasing that first drink feeling the whole time. Yeah. And the only safe thing for her has been not drinking.
Yeah, absolutely.
Yeah.
The other thing I would wonder is drinking at such a young age, what actual impact it had on brain formation.
Yeah.
So particularly because those from that age of, you know, 15 through to 25, so in these early years, all of her impulse control, frontal lobe systems would have been forming, and whether or not it actually interrupted that whole process and suppressed some of that development. Therefore, she would have less impulse control, and it would feed into the cycle itself.
Yeah.
And therefore, you know, if we're looking at the diagnosis bipolar 2, whether the impulse control issues are kind of represent a kind of differential diagnosis for that, given the early onset and the possible impact on brain formation.
Yeah, and I think that's exactly right. And there's a pattern, as we'll see in a moment, and I'll talk about the last things on the slide before we move to the next one, but there is a pattern of poor impulse control in this lady, which will surprise neither of you.
No.
Yeah, and whether that gets labelled bipolar 2 or poor impulse control because of early developmental is a whole big kettle of worms, isn't it?
Yes.
I'm a kettle of worms, I think I mean a
Kettle of fish.
Gee, that'll be fun.
That's right.
Sorry guys, sorry for the picture. Okay. But yeah, she's not only had conflict with one employer, this is a pattern, and this lady is not great with money. She's lost her job several times. She doesn't make good forward planning. She runs out of money and then she's got nowhere to go, and she tends to fall back on her mother and also on her daughter. And you know, just to finish off with that slide, on naltrexone, which actually does seem to help her. It's probably the most effective thing we've done for the alcohol, that and the fact that she stopped drinking herself. Naltrexone, because there's so many different things that you can use for drinking, aren't there?
Yeah, so I'm not an addiction specialist, but in people who do come to me with alcohol as a comorbidity tend to start with naltrexone. Now, I recently looked into the evidence, and my understanding is that it certainly reduces the number of alcohol-free days that people have. And I'm also pretty sure, based on my recent reading, that it can reduce the number of drinks that people have per day when they do drink. I have used it also as a harm minimisation strategy. And the evidence around this is not especially strong, but there are some people who describe, if they take it a few hours before going out or before they're likely to have a drink, that they will have, 5 drinks as opposed to 10, or 3 as opposed to 6 drinks. And for some people, that can make the difference between,
punching someone up.
Exactly.
Yeah.
Or
hopping in a car and driving it.
Not taking an overdose. So occasionally I have found it useful. It's a generally pretty well tolerated drug. Occasionally people have gastrointestinal symptoms when they start it. I think that there's a recommendation about checking liver function tests.
Yes, that's right. Yeah.
And I think you have to be cautious in people with liver issues, although of course a lot of people who do use alcohol will have liver problems, but I don't think it's reason not to use naltrexone. So generally it would be where I start, also because of its ease of use. It's a once daily dose, doesn't interact with other psychotropics, except you have to bear in mind if people are on opiate analgesia, so it will stop things like codeine and oxycodone from working properly, and precipitate withdrawal for people who are opiate dependent.
Absolutely. Yeah, and look, I've had a few people that have been desperate for me to use. I can never remember. Oh God.
Baclofen.
No, not baclofen. Actually, I have had people ask me about baclofen. Yeah. We did have a drug and alcohol specialist, a GP, who then went on and became a drug and alcohol specialist in our rooms, and he did use a bit of baclofen. So tell me about baclofen.
So baclofen is a GABA B antagonist. So the benzodiazepines are GABA A antagonists. So it's very, very similar in terms of its psychological and neurophysiological effects. And there's as much of a risk of developing tolerance and rebound phenomena over time as there is with the benzodiazepines. There is a fashion for using baclofen in alcohol dependence. That's kind of evolved over the past 10 years, but having looked into the evidence recently, because I had a patient come to me on a very high dose of baclofen, the evidence at the meta-analysis level is pretty poor. But anecdotally, there are many people who swear by it. There's websites and support groups dedicated to this particular drug. So it's something that even if you don't prescribe it or don't, not particularly convinced of the evidence around it, you need to be aware of it. And I think in simple terms, it's best to consider it as effectively a benzodiazepine.
Yeah, that's exactly right, isn't it? And look, it's interesting as well, because the one that some of mine come to me and ask about is disulfiram anti-abuse, because they quite like the idea that they could get this horrible reaction when they drink. Yeah.
And again, the evidence for disulfiram is pretty poor. I think in selected individuals, it can be highly effective. So when people are highly motivated, and where you have a family or a spouse on board who's, or you can arrange daily supervised dosing at a pharmacy, and you have to have a fairly well-educated patient with reasonable impulse control, because it can make people very, very sick if they drink. So certainly in selected individuals, it might have a role, but again, the evidence is pretty low level.
I'm glad to hear you say that, because my experience is they come in, they ask me for it, and then they never take it.
That's right. Problem solved.
Yeah, exactly.
And
No, just the father's father. Yeah, no. Yes, I'm sorry, that probably wasn't as clear as I wanted it to be. Always get very. I should have put a genogram up. Do you guys? I think people on this webinar. Well, talk to me about. Do you use them, Tamara? Do you find
Ironically enough, no, but it's something we're taught back at uni days to put everything together in a genogram so you really understand the family history and go back over time. But ironically enough, since starting practice, I guess we just don't. We run on the hop and the information's down there in writing as we keep going.
Yeah. What about you, Julia? Do you use them?
Not as often as I should.
Yeah.
Because of time constraints.
Yeah. No, I understand that. They can take, but I'll tell you what, they are wonderful for making when you've got one state. For people who don't know what a genogram is, it's basically a family tree. And you can put a whole lot of information on the genogram about who did what, who died, and who was divorced, and who separated, and there can be an amazing way of showing people very clearly, very quickly, the patterns in the family, particularly if you then put on the relationships between people. Having hung around the odd family therapist or two, I've sort of been trained in that model. So I quite like using them. Let's go to the next slide, perhaps.
Let's ask you a few more questions.
Yes, please do.
What was the first trigger for her when she was 37?
When she was 37?
Yeah.
So
The
15
first
years
trigger.
ago.
I think it was the break-up of that, the first trigger as in the first trigger for the suicide attempts, yeah. I think it was a breakup of a relationship again, yeah. And I'm just trying to take that, I think at that stage her daughter, that was about 9 years ago, yes, her daughter had not long been born, and that relationship broke up, and that was the first suicide attempt, and things kind of spiraled from there, yeah.
And one more question, what chronic health conditions could be associated with such a case?
Ooh, that's a really interesting question. What is that with such a case? As in, well, I know what was associated with this lady, but is this? I'm just wondering.
Maybe with the
Alcohol.
Yeah. Chronic health conditions associated with, well, there's so many, aren't there?
Yeah, I was just thinking everything.
Yes. It tends to screw up a lot of things in my experience. I mean, obviously liver issues, cirrhosis and hepatocellular carcinoma and all those sorts of things. But if the person who posted that question would like to be a little bit more specific or just tell us if we're on the right track here, that would be great. And of course, it's not good for your brain because it knocks off vertigus, Korsakoff's, all that side of things. What else does it do to you girls? Remind me.
I often talk to young people about drinking in terms of neurocognitive function. I think there's a kind of overemphasis on the liver, which for most people is a very abstract idea. It's very difficult to explain to people exactly what the liver does. Whereas most people can, know what the brain does and can identify with, the impact of, alcohol on brain functioning. So I often tell people, and there's some research evidence to back this up, that there are neurocognitive changes in alcohol use disorder well before there's the first signs of liver damage.
At the Adelaide Clinic, when they do detox, so usually on your initial assessment, you fill out some cognitive forms where we're assessing for that. We often sit down 2 to 4 weeks later with the person and go through them. And it's phenomenal to see that they had absolutely they thought they were perfectly okay that day because we don't do the assessments when they've been drinking. So as far as they're concerned, they are their cognitive functioning is unchanged. And for them to fill out the exact same thing and then see that the cognitive function has rapidly increased, and it does make you wonder, without the detox, how well that person can engage with therapy. And is actually aware of their consequences as opposed to just how much the alcohol itself is interfering, because it is a dramatic change across those 2 to 4 weeks.
Yeah. And I'm reminded of a relatively young smart store recently who had been a senior bureaucrat in late 20s, but had undergone a very significant functional decline, mainly due to alcohol. We did some neuropsychological testing, and it did show some mild but definite impairment that you would not expect in someone with her educational background and pre-morbid intelligence. And I think that helped to some extent reframe her views about alcohol. And as I said to her, which she found very amusing, we want to preserve your brain, but not pickle it. So that seemed to get through.
Okay. And Jackie, that one about diabetes and heart health. That was the extension of those chronic health conditions.
Oh, diabetes. What's does alcohol cause diabetes?
Well, I guess, there's an association with obesity. A specific association with alcohol. I'm not sure about actually.
No, I can't off the top of my head associate the two, unless if you ended up giving yourself pancreatitis to the extent you knocked off your pancreas.
Definitely obesity and hypertension.
Yes.
And in terms of heart health, there is alcoholic cardiomyopathy, which is often associated with nutritional issues.
Yes, that's true. Yes. Mind you, they've often got to the point then where they're homeless and there's all those other kind of things going on as well.
Very end-stage situation.
It certainly is. Yeah, exactly. Yeah. So yes, if we go to the next page, and yes, we referred to the psychologist. Of course, we did that. Absolutely. And my aim was for abstinence from drinking. That wasn't quite the same as her aim was. But we kind of negotiated over time, and we kind of got to the same place eventually. We put the venlafaxine up because we did the right thing from Julia's point of view. Excellent, fantastic. Because I was concerned about it. Then she decided that she'd make a work cover claim. I hate work cover claims when it comes to depressed people and anxious people. What's your experience with that, Tamara?
The moment they finish their claim, they get remarkably better. So look, it's one of those systems where being in the system can actually contribute to some of the issues that goes on. There's a lot of secondary gains, but I don't think it's just that. It's having to feel that you have to justify everything that you do. A real just stuck in the system. It's not as supportive as I would like, and the typical time for a mental health claim from the time you've had your injury to actually seeing a psychologist in their office is at least 6 to 12 months.
You're joking?
Yeah, so it's not a quick process. So from that day of the claim. So it would depend obviously on what it is, because a lot of the work cover claims, it's secondary to the initial injury.
I see what you mean. Yes.
Yeah. And to get approval for sessions and then go through that fight, it's not pleasant. But if you've had a genuine injury and you're off work, I think it has its bonuses, but it's certainly not the system that I would love it to be.
Yeah, exactly. And one of the problems that I find is with people who have what you might call pre-morbid conditions like this, it is so difficult to kind of say, well, this is all due to the job and this is all due to, where do you draw the line? Yeah, exactly.
Psychologically, it's hard to determine.
Yes, so I have to say my heart sinks when I, but thank goodness this lady thought better of it after a few months, which hallelujah is all I can say. I was very grateful for. But by this stage, the daughter was struggling as well. And knowing the daughter as I do, I can say that daughter had been looking after that mother for a very long time, because she remembers mum going off into hospital when she was very little and not quite knowing what was going on, and then having to look after her mother as she got older. So do you see that a fair bit with that, Tamara?
Yeah, so it's... My guess is, and I think someone wrote in the chat that this person had lost every male figure most likely through their life, and I think that's true. But there is a lot of anger and a lot of conflict, because typically if you're using alcohol, you're quite often avoiding which means that on some level you don't like emotions, you struggle, you avoid them. And with that can come out conflict, anger. You've also got the impulse control, decrease. So it's one of those conditions where I think anger is a secondary emotion, so it's something that you often feel off the back of something else. So, but in this case, it would be that, she would be potentially losing jobs, getting angry, having conflict with multiple people around her, take criticism poorly, things like that. So very much think she would lack communication skills to be able to be assertive.
Absolutely.
Or appropriately assertive.
yes, that's a really good description of it.
I see people always say, that person needs to learn how to be assertive, and I think appropriately assertive.
Yes, that's exactly right. Because
slightly different.
There's a very big difference, isn't there? Oh, yes, there is. Absolutely. And so, yes, things got worse, and she got more suicidal, and she landed in the Royal Adelaide Hospital, which is where they made the diagnosis of not borderline personality disorder, I beg your pardon, of bipolar disorder, and they started her on Motrip, which, Julian, do you see that much with bipolar disorder? Is that something that comes in now?
Yeah, so it's a complicated but very useful drug in certain contexts. But I was just going to ask, with the diagnosis, was that based on the historical information about those mood episodes when she was in her 20s?
I think it was based on the impulsive spending.
Okay.
Yeah, exactly. And my take on it, which is fairly obvious from what I've written, is that I think personally that relates more to the developmental stuff. Yeah. Not wanting to sort of second guess my psychiatric colleagues at the Royal Adelaide, but I know a lot about this family.
Yes.
Yeah. And they, of course, are seeing a very small snapshot of what's a fairly big picture. So diagnosis in psychiatry is difficult, isn't it? It just depends on what you see at the time.
That's right. And people can present very differently in different contexts. So I can't easily explain it, but I've seen people who present very differently in the public or emergency department setting compared to when they present in your private rooms. I think depending on the system that you're working in, there can be certain diagnostic biases, and depending on the resources that you have available to you, whether that's whatever level of resources we're talking about, so hospital beds, community mental health team, affordability of private care, that can influence what diagnoses are made. She certainly sounds like something of a diagnostic dilemma.
Yeah, I think that's a very fair comment. Yes, and I was interested as well. She ended up having ECT. Now, of course, I wasn't present during those discussions, so I can't speak to why that decision was made. And the venlafaxine was reduced to 150 milligrams. Do you have any comments to make about that? I'm curious about your thoughts.
Yeah.
Always difficult when you're sort of talking about something that you haven't been involved.
I'm just thinking through a number of things. So, provided that there was an appropriate indication for ECT, so we'll just take that for granted that there was, good reason to give ECT. It's always a dilemma knowing what to do with the antidepressant that they've come in on. So some people take the view that, well, by definition, they shouldn't be on that antidepressant because it wasn't working, because you've had to give them ECT, so you should put them on something else. Some people have more of the view that with ECT, previously ineffective treatments can become effective. There's not as much evidence for that. If we're considering unipolar depression and ECT, the best evidence for maintaining improvement after ECT, after an acute course of ECT, is for the combination of nortriptyline, so a tricyclic antidepressant, and lithium. And there's also some evidence for the combination of vaccine and lithium after ECT. If it were a situation of unipolar depression, I'd be looking at changing the venlafaxine to nortriptyline and adding lithium. And I think, yes, she was eventually started on lithium.
She was. Yeah. Yeah, she was. That was when we, they managed to find a psychiatrist in one of the community teams, and we got continuity.
Yeah.
And that psychiatrist decided that, and the laboratory, oh dear, that was a mess. Yes. Yes, it never helps when they don't tell the GP what to do with the laboratory. Yes. And let me tell you, as a GP, that happens a lot.
Yeah. So for people who don't know, it's critical to titrate lamotrigine very, very slowly. So I tend to titrate by 25 milligrams per week to a target dose of 200 milligrams. There are some people who would be even more conservative than that in terms of the rate, so 12.5 milligrams per week. Many of you probably know the concern about Stevens-Johnson syndrome. The thing that makes it even more difficult and confusing with lamotrigine is that about 10% of people develop a benign rash.
Oh, seriously?
Yeah.
Oh, great.
So there's the 1 in 1,000 who develop the death rash, and there's a significantly higher number who develop the benign rash. And that's a tricky situation because many people can still be treated on lamotrigine with the benign rash. You can slow down the titration, but you really need to have a handy dermatologist on call to be able to make that clear differentiation. I tend to avoid starting lamotrigine people who've had any history of rash with medication. So, penicillin rash or anything like that. I think there is some evidence that there is a degree of cross-reactivity, I don't know if that's the right word, but certainly increased risk. Yes, it can be a conundrum what to do if you get the benign rash, which is a rash that doesn't involve mucosal membranes. So the thing with Stevens-Johnson is it can involve mucous membranes and associated with systemic symptoms like fever and wrinkles.
They get pretty sick.
They do get very sick and can end up in burns units, unfortunately, and I've seen that. And just with lamotrigine, it's, I could talk about it all night, but in brief, it's not a treatment that has evidence for acute efficacy. Although I have seen people who appear to respond acutely, it has more evidence in terms of prophylaxis or prevention of depressive episodes in bipolar disorder. So it's not thought to have an acute benefit, but it has prophylactic or preventative benefit, and does not have any benefit acutely on mania or prophylactically mania. So you don't use lamotrigine to treat or prevent mania, but it can be useful in preventing depressive episodes.
That's really useful information, because I didn't get told any of that when she came out of hospital. It's like, here you go, deal with this.
I think given the predominance of depression, if we're saying she does have bipolar, and given the predominance of depression in the clinical picture, it's not an unreasonable medication to try. But then there's controversies about what you do with antidepressants if you're saying that she does have bipolar disorder, because there's evidence that antidepressants can destabilise the overall course of bipolar disorder. But in reality, many people with bipolar remain on antidepressants. And there's very much a split in the bipolar kind of professional community about the role of antidepressants. But most current treatment guidelines in terms of bipolar depression recommend avoiding antidepressants unless absolutely necessary, due to concerns about inducing mania or mixed states.
Yeah, absolutely. And that's certainly what I'm seeing is more and more my patients with bipolar disorder are maintained on a mood stabiliser.
Yes.
Yeah, without an antidepressant.
Yeah.
So yes, we fiddled around. I think they fiddled around. I can't remember who fiddled around with the dose of quetiapine, but one of us did. And then we found a really good psychiatrist in the public system who the lithium really worked well for her. unfortunately, lithium, as we all know, has rather a lot of side effects, and she wasn't too thrilled about the weight gain. I wouldn't blame her.
No.
No. Weight gain and depression, and talk to me about that tonight.
Yeah, really common. So it's probably one of the first signs. So is it was a change in weight. So at times it can go the other direction. But certainly on trying a lot of the medications, I think there's a few studies around if people started some healthy living programs at the same time as being prescribed some of the medications that have the rapid weight gain, that they could overcome a lot of it. So some good research around that. But overall, I think it's one of those things, particularly being female, where the person might actually choose not to take their medication just because of that side effect alone. And I think it's probably under considered at times. The other element, the bipolar diagnosis and the focus on medication, there's some really interesting cases I've had with bipolar where on diagnosis, it's actually a lot of grief.
Yes.
Particularly because it's around that 15 to 25 age group. So this concept that the plans I had for my life can never happen, my mood will never be predictable. I'm not capable of that job or that uni or that career or whatever it was I was intending on. So I think even around diagnosis, I often find there is about 12 months there of intense grief.
Yes.
And a lack of understanding of what it means itself. And when people say, oh, you're always going to have breakthrough episodes, that sense of I'm never going to be able to have control or know that I'm predictable, and a lot of fear about their own brains.
Yes.
So, this thought that I can't even trust my own thinking on a given day. So they did a really lovely research study over in Melbourne, where they took a group of treatment-resistant people with treatment-resistant bipolar who were refusing medications because of the various side effects, and put them through a psychology training program where they learned how to modify their moods, how to monitor them, notice early warning signs. It was a group program, I think 12 weeks. And just through it, just teaching them how to notice a mood going up and what to do to increase or decrease stimuli to the brain. And they found that in the corresponding 12 months, the group had no manic episodes.
Oh, really?
Yeah, no manic episodes reported across a treatment-resistant group, and no hospitalizations.
Wow.
So while they reported depressive episodes, they had managed. So I guess for me, it's the combination of the medication along with learning those techniques, and so that they have hope that, I can actually get predictable in how this goes. And I think those two in combination, so obviously I think my preference is not without medication, because I think the actual combination is stronger.
Yes, I think.
Than the two alone. But if you do get someone who is flat refusing, just to know that there are other options that can at least complement whatever you're working on, especially if weight gain is something they just won't.
Yes.
Or teenage. I mean, you can imagine.
Oh, I can. Absolutely, I can. Do you get much of that, Julian? Have you dealt with many teenagers where?
Yeah, absolutely. And I'm seeing a young woman at the moment who is very complex. She has kind of complex trauma background, but also probably an emerging bipolar illness, and significant body image issues that often go with the complex trauma picture. A lot of disordered eating, often binging, binge purging, and so marked weight fluctuations around that. So it's a real dilemma as to what to do with her medications, because if we did something that started significant weight gain, that could lead to real distress, I think, in her case. So we're just sort of working through that at the moment. I've started lamotrigine, which I should say with lamotrigine that apart from the death rash, it's an extremely well tolerated drug, so it's not associated with weight gain at all. It's not particularly sedating. In fact, some people find it mildly activating. and people don't mind taking it. So it can be a very useful medication in the armamentarium for bipolar. I was just going to ask, with the lithium and weight gain, was she still taking Seroquel at that time?
Yes.
Yeah.
Of course she was.
Because I have to say that significant weight gain with lithium, in my experience, is that common, and I would be much more suspicious of the Seroquel than the lithium. But often people attribute certain side effects to particular medications, so they'll have a very clear idea that this medication causes this and this medication causes that. So I don't know, but I do wonder.
Yeah, I think you're probably quite right. Yeah, exactly. And it is a bugger for weight gain, isn't it? Yeah, exactly. And we started a bit of metformin just to see if that helped at all. Is that a reasonable thing to have done, do you think?
Yeah, I think so. There's good evidence that metformin can attenuate antipsychotic related weight gain, and there are some guidelines that suggest that it should be, or consideration should be given to starting it as soon as you start an atypical antipsychotic, particularly olanzapine type.
Oh yes.
The evidence, I think, is more that it attenuates weight gain rather than helps with weight loss.
Yes.
And particularly, for it to work, it has to be done in combination with lifestyle modification and exercise. So it's probably better than lifestyle modification exercise alone, but definitely worth trying.
Not going to work miracles, but it
No,
might stop them getting horrible cholesterol and diabetes. Yeah, exactly. Yeah, and yes, she has had lots of trials of lots of different, a very good psychiatrist who unfortunately is just retired, so that's a bit of a shame, but you know, that's okay. We'll just use it, because unfortunately she didn't actually want to go and see anybody else, so she's managed to just kind of quietly avoid it.
Right.
And we'll get there. It'll be okay. But yes, the psychiatrist has tried all kinds of things, and she got the rash again on the launchpad. So there you go. It was probably a benign rash.
It was,
But you know what? I'll bet you anything the psychiatrist was even less frightened. You know, we were all just a bit scared.
Yeah,
so.
fair enough.
Yeah. And she's back on venlafaxine, and watch this space.
Right.
Yes, because you know, she's just. I put more in there. I think I did.
Yes,
I did, didn't I? Oh, look at all of that. Oh my goodness. Yes, and she's got all kinds of exciting things going on. Migraines and hemicrania continuity. Well, that's what we decided it was called in the end. Some sort of weird headache, and she's waiting for a cholecystectomy. And her current medication is a whole hodgepodge of things. Is that? It seems like a lot of different things, doesn't it? But is that a reasonable kind of? I mean, not wanting you to. Oh, it's difficult. It's not a psychiatrist, of course, but yeah, it is a bit of a mixture.
Yeah. So I guess just going through them individually, lorazepam is a newer atypical antipsychotic that's come out in Australia in the last 5 years. It's only PBS listed for schizophrenia. And off-label is quite expensive. It has, apart from schizophrenia, very good evidence in the treatment of bipolar depression. And it might be that this was the justification for using it in this particular situation. It metabolically is relatively friendly compared to other atypical antipsychotics, certainly much better than thiopine and olanzapine. Problems associated with it can be nausea and anesthesia, and it's a bit tricky in that you have to take it with food in order to get the bioavailability. So you have to take it with I can't remember the number of calories, but I think it's essentially like a reasonable sized dinner, like a chicken salad or something like that, as an example I give people, in order to get proper bioavailability. So you need a reasonably reliable patient if you're considering lorazepam. So in the context of bipolar depression, a good choice, I think. Lithium, I wanted to make the point before that lithium can be effective as an augmentation strategy in unipolar depression. So that might have been one of the reasons that it was used. But the dose range suggests that it was probably being used more for bipolar diagnosis.
Yeah, and this particular psychiatrist also has a thing about the menopausal women, and all having HRT as a. Is there? I'm just not sure if I don't know about the evidence for that. I'm sure this person has. It's I'm sure they've got very good grounds for it. Yeah, is that something that you know much about?
I don't know much about the evidence base for HRT in mood disorders in the menopausal kind of phase, but clinically, there's a group of women with pre-existing severe mood disorders who very much decompensate around the menopause, and it can be very difficult to regain control of the course of their illness after that. And I think it's a reasonable discussion to have HRT in that context.
Yeah. From a psychological point of view, menopause, obviously there are hormonal things.
Yeah. So I think from a psychological point of view, it's usually not necessarily understanding why this is happening. So they'll talk a lot more in terms of physical symptoms and having, hot flushes, I remember having this, and don't necessarily assume that that's a very emotional behaviour, the increase in anxiety that they're experiencing, anger, mood fluctuations, all the stuff you expect with hormones. They won't necessarily attribute that to hormones per se. And have had a case before where someone was suffering bipolar disorder, was very stable for 10 years or more, and in the context of menopause actually had a complete relapse, and the hormone component wasn't diagnosed. So I think just anyone in that sort of age range, and the evidence, as Julian said, is quite strong that if you've had any episode at any time in your lifetime and you have menopause, it's highly likely that you will have a relapse. So just that concept of, if they have a history of postnatalism, then you could anticipate at that next hormone change that they would have a episode of some sort. So just consideration of linking those two, because I think otherwise they feel quite irrational, and that this doesn't make sense. And when it's so medically or hormonally driven, and that may not be necessarily picked up by the psychologist either.
And I think that's an important point if we think of across the lifespan of women. There's 3 major peaks of psychiatric disorder occur around those major hormonal shifts. So puberty, and then pregnancy and childbirth, and then the menopause.
It's interesting though, and I've always wondered about this, because they are definitely hormonal changes, no question about that. But they're also transitions, aren't they? Yeah. So you never know which is which, really, do you? Yeah.
I usually say it's the combination. If you were sleeping and you had hormone problems, if you got the two together, it's really a recipe for disaster. So, having a child not sleeping, having hot flushes, not sleeping, that maybe without one or the other, you might be able to manage some of the symptoms a little bit better. And I think anxiety and panic is on all of those different life changes, and is fully understood that it might actually present as anxiety and not as a depressive syndrome. So I think, especially postnatally, anxiety is very much postnatal condition, and not necessarily just to think of it as someone who's depressed or even particularly worried about the child. Panic attacks are incredibly common. Flare-ups of OCD, if they had any type of pre-existing.
Oh, I've seen it where I wasn't the clever person who diagnosed the OCD. I knew the person was very, very anxious, but it was a psychiatrist who suddenly put the things together, and the child had a number of cafe au lait spots, pigmentations, and there's something not right about this. It was OCD. Of course, OCD. But you know, it just didn't occur to me. Yeah, exactly. And once we made that connection, he's got a lot better. Yeah. So,
And Jack, you got a question here.
Yes.
Did anyone explore the concept of a diagnosis of chronic and complex PTSD in this section?
oh yeah.
Given the history.
Yes, I think that's a very fair call. Not in terms of sexual abuse, childhood sexual abuse or physical abuse, no. Certainly growing up with a father with alcohol issues, you don't escape unscathed from that. So I think, you know, from that point of view, yes.
And some of the relationship issues you think would be indicative of it.
Exactly. Yeah, that's
and
right.
What happened to the Aryan, I'm going to say this wrong.
Aryan
That one.
Yes. I don't think she continued with that. I think that was one of the things that got tried. And this is a lovely psychiatrist who writes me letters every time she does something, which means that there's so many flipping letters that I can't keep track of it all. So I know it's sometimes you can have too much of a good thing. Right. Yeah, exactly. So I think that got stopped somewhere around, you know, last year sometime, because I don't think she tolerated it very well, and I cannot remember what side effect she got, so I apologise to the person who answered that question.
Typically, people would stop aripiprazole because of nausea and akathisia.
It might have been akathisia. Yeah. Yes. So I think we'll probably talk through that case. Do you think, guys?
Yeah, I think so.
Yep. Let's move on to the next one, hey? Yes. Oh, yes. This is one of my teenagers who I've grown up with, or she's grown up with me. I'm not quite sure which way around it was. Yeah. And this one was one who got referred in by her psychologist because she was expressing a fair level of suicidal ideation, and the psychologist wondered if she might need some antidepressants, brought in by her mother, and very typical kind of teenage stuff. Sleeping a lot, and you know, sort of pretty miserable, cutting herself, really pissed off at her parents, which is not unusual in teenagers. An older brother who was 18 months older, and here we've got that alcohol thing again, haven't we? Yeah, because Mum's dad, a heavy drinker, and I actually see another sister, the aunt of this lady, of this woman as well. So yeah, it's pervaded that family, that's for sure. And then Mum's sister, exactly as I just said, the auntie with antidepressants. And then there was some separation anxiety when the young lady in question was little. Our mum was in hospital for a period, and there was some separation anxiety when she went to kindy as well. She wasn't drinking at that stage, and no illicit drugs, and a non-smoker. And I must admit, that one, it was a long time ago. I'm a bit wiser now. And I think we did actually start some antidepressants. Do you mind going on to the next slide, Julian?
I was just going to ask, what was your cross with her parents about?
Oh, very good question.
Apart from everything.
Yeah. Well, we'll get to that. Okay. We'll get to that. Yeah. Don't get too far ahead of me. There was a very good reason why she was cross with her parents. Yeah. Absolutely. And the medical history, well, you know, the endometriosis came up later, Thompson's peptic ulcer came up later as well, probably related to the endometriosis because she was taking some anti-inflammatories to deal with the pain. I started her on escitalopram, and I can't actually remember why I started her on escitalopram, but I did. And then I sent her off to a psychiatrist. I think I started on escitalopram while I was waiting for her to get into the psychiatrist, who then changed it to fluvoxamine. And Julian, you deal a bit with teenagers. Yeah, a little bit. I know they're not your main focus, but you know. And teenagers and antidepressants, it's an interesting area, isn't it?
Yes, a controversial area, particularly in Adelaide.
Oh, yes, you should say that. Yes, I know exactly what you're talking about. Yes, exactly. Yes.
And it's been debated vigorously and passionately for the past, we're getting on to 30 years.
Yes, it's about right, yes.
And the more or less official position with antidepressants in adolescence is that yes, there is an increase in relative risk of suicidal ideation after commencing SSRIs, but the absolute numbers remain very, very low. So if we're talking the population of thousands of children in a clinical trial, the relative risk might be 2, but you might usually only have 1, 2 or 3 or 4 children actually having suicidal ideation. So yes, in a statistical sense, there does cross statistical significance, but the absolute numbers are very, very low. And the risk that I guess the concern about suicidality with antidepressants runs is that many children who would benefit from treatment potentially go untreated or undertreated because of it. But that is just a very, very brief summary of a very complex debate that I don't know too much about. Most people would start with fluoxetine because that has the most evidence. Fluvoxamine has much more evidence in adolescents for anxiety rather than depression. This is not an uncommon situation of medications possibly being underdosed. So fluvoxamine can be dosed as high as 200 or 300 milligrams per day. Was there an anxiety comorbidity here?
Yeah, in retrospect, of course, there was. Yeah, absolutely.
So I think that's with prescribing, there's quite good evidence that with SSRIs that higher doses tend to be more effective for anxiety than the lower doses. So to take the example of OCD, versus depression, so many people who respond to sertraline would respond to 100 milligrams, and there's actually not much evidence that high doses of sertraline are effective in depression. Whereas there's good evidence that doses of up to 300 milligrams have superiority. And that probably generalises to many of the other anxiety disorders. So if there's significant anxiety comorbidity, then you'd be thinking about a robust trial of a higher dose. But particularly early on, you want to be scheduling very regular follow-up because of theoretical risks of unmasking suicidal ideation behaviour, agitation.
Yeah, absolutely. Yeah, and I think yes, we finally did settle down on desvenlafaxine, and that seems to have worked quite well for her. And we've got away with 100 milligrams daily, which isn't a huge dose, but that seems to work for her. But I think when we get to the next slide, you'll get the keys of why.
The real issues.
Yeah, the real issues. Yeah, and the real issue came out about 6 months after she started seeing me, which is that she's same-sex attracted, and she had a father who was a very strongly Eastern European Catholic and did not think that homosexuality was a good thing in any way, shape or form. And she was able to divulge it to her mother over time, but there was no way she was going to be able to tell Dad for quite a long time. And then we had 10 years of fun and games. We kind of weathered the storm of a whole lot of stuff. And boy, oh boy, did she give her mother a run for her money. I've seen worse, but it was interesting. And a lot of my job was holding Mum's hand and saying, it'll be okay, hang in there, she'll get through it, it'll be all right. And it was, in the end of it. So in a sense, we were mothering the mother. Is that something that you kind of did? Yeah, go on, talk to me about that.
Well, so just look, I think teenage years are hard.
Yeah.
But if you get through them, then it's okay. So no, I think it's that whole thing of there is just that natural impulse control. There is that natural exploring who you are, and if you have sexuality issues on top of this, you've got identity issues. And you've got a sense of not belonging and where do I fit, and your social group that you would normally receive a lot of your identity information that necessarily isn't there. And certainly if you're then experiencing that at home with your parents, on top of that, I look at all this and I think that this is that question over, that is there an axis 2 going on? There's some personality issues that could be rife through this. They may settle. So I think, not suggesting that she had it, but borderline personality disorder, for example. We know
that got mentioned somewhere on the track. Yeah, don't worry.
Yeah. Well, it tends, in general, there will be a group that will actually get remission by the age of 40 and around that, just naturally. And to me, that's brain stability and then testing out some of these boundaries. But the fact that she went on to lose her mother, I think, is the part in all of this, given that was her greatest support. The person who most understood her and the concept that dad, even if he did later accept the choice of partner, may still not be the most supportive person. So the fact that she lost that when she was in the middle of, still forming her identity across those years.
Yeah, well, actually, it's not quite as bad as it sounds, because, and I perhaps haven't made that clear on this slide. She was very lucky. It's not lucky to lose your mother. God, that's never lucky. But she's very lucky in the sense that they had worked through so many of these issues. And I remember, because I did the palliative care for Mum, and Mum was about 56. She got pancreatic cancer, and it was incredibly fast. From diagnosis to death was, I think, about 2.5 weeks. It was awful. It was just awful. And my mother that I'd looked after for a while, so it was hard going, but for everybody, it was not easy. But the one lovely thing that I remember talking to this mother about was the fact that she'd got this daughter through to the point where she'd actually individuated successfully, she'd developed a really strong identity, she'd got herself into a career that she really loves doing, and she'd got a partner. And she was going to be okay. And that's exactly what's happened. She struggles a bit, she's still a bit wobbly, she sees a psychologist, but she's in a good relationship and things are so good going forwards. And Dad is actually seeing the light as well, because he kind of did the maths and went, I could accept her sexuality and I'll still get my daughter, or no, maybe I'll accept her sexuality. He's a bit of a dork. I remember when this lady passed away in the middle of the night, and I went to certify the body. As we kind of came out into the summer night, and he said to me, I'm going to have to learn how to use the washing machine now. And his daughter just looked at him. She was about 20-something then, and she just rolled her eyes at me, and I rolled my eyes back, and on we went. But it's a good outcome from this one, but it was very rocky there for a while. Yeah, very, very messy. And I think what's nice about this case is that sense of hope that you can have with teenagers. That if you stay steady, and you give them a steady base, and you give the parents a steady base, it can work through okay.
And I think there is, given she had her mother through all of this, there is really strong research around the fact that you only need one good, solid, supportive role model can be a grandparent, and your outcomes are really, really good. It's actually the loss of everyone. So if you ever have a family where you know that it's unstable for multiple reasons, if you can encourage or bring in that one supportive figure, whoever that may be, and encourage that relationship to form, they have much better trajectories through their lifetime.
Ain't that the truth? Yeah. Julian, is there anything about this one that you think is particularly worth bringing out, or if we kind of talked through most of the stuff in it, what do you think?
No, well, I was just reminded of a young lady I saw recently from a very, very conservative religious background, who presented to me with what superficially appeared to be quite a severe biological depressive illness. We did a couple of things with medication and we weren't getting anywhere. And I just had this persistent sense that I was missing something.
Yes.
It turned out that she was same-sex attracted, and that came out about two months or so after we started seeing each other. and kind of in an unguarded moment, she blurted it out to her mother, which led to this kind of brief crisis within the family. But then she retracted what she said.
Oh, she was trying it out, wasn't she?
Yeah, that's right.
Yeah.
And everything was kind of swept under the carpet. And at that point, she disengaged from me and from also the psychologist that she was seeing.
Yeah.
I don't think she was ready at that point.
No, I don't think the family was ready
and
either.
the family wasn't. So, yeah. So, yeah, just reminded me of that. It's, just shows how the diagnostic formulation needs to be revised over time in the light of further information. You can only work with what information you have at the time.
Yeah, and from mine, I would just say that what I have noticed is people get very caught up on how the parents will react in the short term.
Yeah, that's right.
And, often just reminding people that an initial reaction, or even as you as a parent are going through something when you get this kind of information, and that you have to go through your own process of acceptance and educating, I think, the young person on what to expect, and that their focus will very much be on the response to that first conversation, and just realising that your parent is on a journey too.
Exactly. And that was the nice thing about, this is the lovely thing about being a GP, is that you do get to treat the whole family if you're lucky. And I could say to Mum, look, Mum could come and talk to me about the fact she did. She'd had a lot of grief around it because, it wasn't what she'd expected. It wasn't that she was homophobic. It wasn't what she'd expected of her child. And
What Tamara was saying reminds me of when I was working in consultation layers on psychiatry. And, one of the most frequent consult reasons would be someone given bad news about cancer or terminal diagnosis, and in that context kind of refusing treatment, and it was very difficult to get medical teams to see that the acute reaction may not necessarily persist, and there was often pressure to get the guardianship tribunal involved. Involuntary care, but often supportive counselling over a period of a few days could turn the situation around.
Exactly. You need to just give it time sometimes,
right.
don't you? And just coming back to what you were saying about the person that you were seeing, I've also had a situation with a young person who we did not know what the hell was going on with this young person for ages.
Yeah.
And there were weird psychotic symptoms. I think the psychiatrist just was puzzled as I was, until it eventuated that he was transgender.
Yeah, so that's what I was thinking in my head, that when clinical presentations don't make sense, I have a strong index of suspicion for several things. So often gender dysphoria, and also autism spectrum disorder can present in weird and wonderful ways, and I always bear that in mind when I can't really make sense of a presentation. There's a lot of disparate symptoms and phenomena that I can't kind of hang all together.
Yeah, it's worth keeping in mind those things, isn't it? Yeah, absolutely. Let's go to the next one. Oh yes, now Julian, this one will be it's right up your street. And I've had this one actually came from GP Liaison Land, because I was contacted by the GP to expedite getting a neurology review. So this is a lady who was living alone in Australia, quite highly educated. English wasn't terrible, but not, when you speak English as a second language and you haven't been educated in English, of course it's going to be limited. And becoming more cognitively impaired over a period of 6 months, more forgetful, more vague, not seeming to understand basic instructions. And the example that the GP gave me when we were sort of talking with this neurologist was that there was a rash that he was treating with topical steroids, and He had to explain it to her multiple times, write it down multiple times. She'd then gone out to the front desk and come back because she still couldn't remember or understand. And you always wonder, is this language-based? But this GP had known this person before.
Right, so it was a change. Yeah.
Exactly, that's right, exactly. And then she'd come back 3 days later and still didn't seem to understand. So, you know, at that point you think, well, if this is someone that you know and someone, exactly, there is a change. There was a history of her father having recently been diagnosed with a glioma. There was a history of a grandparent, I think it was the father's mother, had possibly a brain tumour, but it was a really unclear history. What was interesting to me was that she was estranged from her family in China, and this isn't my patient, so I don't know a lot about that, but I do know that there was some sort of rift in that family. Very few supports here. The GP didn't think that there was some anxiety. He didn't think it was the main factor. And her friends was really worried about her, so it was a GP. And he'd done bloods, thyroid function, blood picture, liver function tests, ESR and CRP, which were all normal. He hadn't done a B12, so there were some missing pieces. He'd done a CT, which showed, I actually can't remember what the name, but it was something that I looked at and I thought, I don't think that's anything of significance, which is what the neurologist felt as well. Not expressing any suicidal ideation, but he was really worried that she was so different. And had a strong feeling that it was an organic thing.
Sounds like it.
It does sound like it, but you know, it's interesting, isn't it? Because I wasn't so sure. And I say this without having seen the patient, but yeah, I don't know. Anyway, if you go to the next slide. And there were a few funny little things. The neurologist, when she went through, and this is a lovely neurologist that I worked with in Royal Adelaide, went through the history, and she said, oh my God, there's a thing about alcohol dependence. And I'm thinking, that is a little bit odd for somebody from mainland China in that sort of age group. It's not, because I've worked with a fair few Chinese people over, and it's not something that I've seen a lot of in that age group. So, but the GP, when he went back and looked at it, because we kind of said that, he kind of went, oh shit, that's something I missed myself. But she really wasn't drinking anything at the moment, and in the past she'd only been drinking 2 glasses a night. So I don't know where that had come from, but anyway, it was there. No illicit drug use, non-smoker, nothing in the way of psychosis, although of course caveat, language barrier, you never quite know. No significant medical history, no medications, really concerned GP. And I can understand that because when long story, but I actually ended up bringing her because we decided in the end that it was probably best that she went to the hospital after consulting with the neurologist. When I rang her, I was really glad there was a friend there. Because I didn't know that she was going to be able to get herself into the hospital or pick up, sort out the referral. So she did get admitted because she really wasn't coping very well. Extensively investigated in hospital, and she had everything. She had the neuropsych testing, the neurology assessment. I can't remember all of the investigations, but there were lots of them. In the end, it sort of all came to this was tumor dementia was the eventual conclusion based on the neuropsych testing, and because they couldn't find anything concrete to hang their hat on, so they popped her on some sertraline and sent her off with the dose to sort of be increased over time, and then referred her to rehabilitation at home. I mean, is this something that you would kind of have seen as a CL kind of person? Or?
Well, yeah, except this is more perplexing.
Thank you. I'm glad you say that. Talk to me about the perplexing.
Most of the perplexing CL cases that I've seen. So had she improved by the time that she was discharged from hospital?
Not completely, no.
Right.
Yeah,
okay.
I know, which is really interesting, isn't it?
Yeah. So depressive pseudodementia would be extremely uncommon in a young person, particularly if she didn't have any psychomotor retardation. And I'm not sure how she presented, but
Yeah, no, not so much psychomotor.
Yeah, so that would be very, very unusual. The other thing that comes to mind with pseudodementia is that there is reasonable evidence that people who have that diagnosis, present with pseudodementia, have in the long run a higher likelihood of developing an organic disorder, and that it may, in a sense, represent an unmasking of an underlying issue. The thing that came to mind when I first read it was the possibility of an autoimmune condition, particularly an autoimmune encephalitis. I presume she had a lumbar puncture in hospital.
Do you know, I don't know that she did.
Right. Okay.
Yeah, that's an interesting one, isn't it? Isn't it? Yeah.
So over the last 10 years, there's been increasing recognition about a group of conditions. Autoimmune encephalitis. There's a fantastic movie on Netflix about a young woman, a journalist in New York, who developed anti-NMDA receptor encephalitis. I think the movie's called Brain on Fire. And she was diagnosed with schizophrenia, and ultimately this other diagnosis was made. So it's a disorder of mainly young women, usually more in their 20s than in their early 30s, who develop an acute or subacute cognitive and neuropsychiatric illness, often associated with seizure-like episodes. Most often they present to psychiatrists before they do neurologists or the medical setting. And there's probably a whole range of antibodies out there that we haven't recognised yet, because I've had a number of, when I was a CL psychiatrist, a number of perplexing presentations like this, where there didn't seem to be convincing evidence of a psychiatric disorder, but we couldn't identify an underlying neurological issue. And from year to year, there's more and more antibodies that are being identified that have caused the autoimmune encephalitis syndromes. So that was the first thing that I thought of when I looked at that slide. And just because you can't find the offending antibody doesn't mean that, or the offending underlying cause doesn't mean that it's not there, because there's stuff that we're learning about all the time. This strikes me as very unlikely to be a psychiatric disorder.
That's really interesting.
Yeah.
Yeah.
The only thing is, it would be interesting to know how the father presented when he had his glioma. So whether his presentation had a cognitive component. A more esoteric idea would be whether she had kind of a conversion disorder. So she's displaying neurological symptoms modelled on, unconsciously modelled on things that she's previously been exposed to, and in the context of, stresses that she might be facing, being, single, socially isolated, having limited English, all of those sorts of things. That's another kind of idea that comes to mind.
Yes, I wondered about that too.
The other thing is, if not illicit substance use, then perhaps use of prescription medications.
Traditional Chinese
or traditional Chinese herbs, particularly if she did improve in hospital for she didn't really, but if she did improve in hospital for no other reason or no apparent reason, possibly, there was undisclosed substance use. I wonder if she received antivirals, so acyclovir in hospital often.
No.
Often these sorts of patients are empirically given antivirals because of concern about encephalitis, and they improve. So you wonder whether there's, viral, syndromes out there that we don't know about.
Probably.
So it's a very rapidly expanding area, neuroimmunology.
It reminds me of a case, not case, a lady that we had, a terrible story really, who made it down to C3 back in the days when we had C3 at the Royal Adelaide Hospital, and had been sent to us because they thought it was a conversion disorder.
Yeah.
And I remember Prof. Pulowski saying, "Oh no."
Yeah.
Yeah, I know that dates me, doesn't it?
Yeah.
Yeah. She had Creutzfeldt-Jakob.
Right.
It was awful. It was just an awful thing. So yeah, and that poor woman had to basically put up with people not believing her and thinking that she was making the symptoms up. It was dreadful, just dreadful. Yeah, sorry, you've got a question, haven't you?
Yeah, what was happening for her and her husband to divorce? Was it cultural?
I don't know. I wish I had known. I don't know as much about this case or this lady as I wish I did, because she's not my patient. So I'm only going on what I was told by the GP, and that information wasn't shared with me. But yes, I think that's a really good point. Yeah, you do wonder about the shame of being divorced. Yeah, I don't know. There's a lot I don't know about this one that I'd love to know, but sometimes you don't get to. Yeah. So yes. Tamara, any thoughts that come to you?
I also agree with Julian. This does not sound psychiatric to me. Could there possibly be secondary gains and things like that? It still feels that would be unusual from the case information that I have. So usually with conversion disorder, you see very clear secondary gains and the people around them, whereas she doesn't actually have people around you, whereas those secondary gains tend to co-occur in family environments and things like that. So I'm not seeing that kind of information. If I go away from this particular case and into your pseudo-dementias, so I think I've had a lot of recent cases lately of query diagnosis for dementia when they've done all the neuropsych testing, but they haven't actually had it, and they present usually around the time, so sort of around retirement, but pre-retirement, where they have actually, they've gone through all the dementia tests, really querying their memory is not what it used to be, and they're worried that they have dementia. They then get anxiety, and from the anxiety and the depressive symptoms, their cognitive function reduces, which reinforces for them the concept that they have dementia, and then lands them in my office, because they're, all the treatments medically have been exhausted, and it does not, and despite being on antidepressants, it does not appear to be changing things, because now the anxiety itself is decreasing the cognitive function. And almost without fail, all of those cases have had extraordinary memory. When they were usually the nurse in hospital who could remember absolutely everything without ever needing a notepad. And I just think it's that memory declining from 25. But at some point it reaches that moment where you notice that it's not the memory that it should have been. And the rest of us who don't have that extraordinary memory wouldn't notice that change. So, but I have had numerous cases of that in the last 5 years that I think it took them quite a while before anyone diagnosing it as psychological dementia. So, but this case, I tend to agree. I don't see the components that would suggest it's psychological. I'd be much more interested in really clearing up that medical history. If it arrived on my desk and I had to work under the assumption it was psychological, I'd be doing basic behavioural activation, but that would have occurred in hospital.
Yes, it did.
So you would have had all the increase in stimuli there. So if they weren't improving, it would be highly unlikely that you would discharge them and create that same level of stimuli in someone who lives alone and isn't particularly English speaking. So I would actually suggest readmission to have
inpatient rehabilitation, cognitive rehabilitation. If allowed.
Well, it was interesting to me that when she was discharged, there was still a significant level of disability. So I must admit, I'm glad you two were saying that, because that's what struck me as well. And it's interesting what you say about the dementia and depression stuff, Tamara, because I've also seen it the other way, where we thought it was, well, there was probably some depression as well and anxiety, but when over time it declared itself as that actually being the start of dementia. So you see it both ways, don't you?
Yeah, so first episode, the onset of dementia is almost always depression. So you'll often see depression as that first symptom, which means neuropsych testing can easily tease out which one of the two it is and give you that differential diagnosis. So if you're seeing depression that hasn't occurred for the rest of the lifetime is popping up there, and you're also querying whether dementia is possibly in the background, it's highly likely it is that real differential. And I think because people are older, we tend to just sort of go, put it to the side and leave it. And I think that's probably one of the worst ones as they watch things decline. But a lot of people say that the depression is because they've realised their memory is declining and they're worried about that. So, but we don't have as many neuropsychs in our neighbours.
I know.
Ideal.
Oh my God, I know.
Yeah. So I would say you've either got to find a clinical psychologist with neuropsych training, or you need to find a neuropsych somewhere in private practice.
Good luck with that is all I can say. And I know the one at the Royal Adelaide has a waiting list that's as long as well, I don't know what it's as long as, but it's a very long thing.
Yes.
Yeah, so it's not easy, is it? No, absolutely. On to our last case. And this is another one of my teenagers. They're so much fun. But this one is not one that I would count as a success story, because this one has really been tricky, and there's a lot of reasons why it hasn't worked out as well as it should have done. One of them being this thing called ice, which is not a great drug to get involved with as a teenager. But I've known her since she was a twinkle in her mother's eye, and I look after this mother and the sister as well, and she's now 19. In fact, she might actually be now 20, thinking about it. And one of those ones, parents separated when she was 12. They'd had a very conflictual sort of marriage. The parents had very, very different approaches to parenting. And I actually know someone who, obviously I haven't talked about what goes on with this family, but I know somebody who knows this family, so I've got a little bit of collateral information.
That's a very Adelaide.
It's a totally Adelaide thing, isn't it? Yeah, exactly. And they talk about their daughter going to a party with this kid, and this kid, I don't know, must be about 8 or so, and this kid shoving her daughter into the pool, and the mother kind of going, oh no, she can't help it, and the father going, right, you out, you go to your room right now. So very, very different approaches to parenting. And I've said that the father very laissez-faire to the last moment. It's one of those people that lets it go, it's the mother who's supposed to be doing it, and then comes down as hard as possible. The mother sort of has a long pattern of, oh, she can't help it, I need to rescue her, anyway. And it was not a good separation. It was a very messy, very nasty separation, living with her mother, seeing a bit of her dad. And, Dad got her smoking marijuana at 13, and then said, okay, if you're going to do that, it's your choice, but you have to be prepared to take the consequences, which is not my idea of parenting 13-year-olds, because at 13, you don't actually think about consequences very much, do you? Exactly, yeah. And then taught her how to make a bomb out of a Coke can, which she then laughed about when she was older because she thought it was pretty lame. That's, oh, great. So, this is not a great start to life. And then we had lots of marijuana, lots of conflict with her mother, some very violent, angry outbursts, and a bit of involvement with psychiatry here and there, and quite rightly, they've been actually, said, yeah, and said, look, this is about the marijuana, which is a fair cop. A psychologist who thought maybe she had bipolar disorder, I wasn't so sure. And a lot of diagnostic kind of hearing to it. Yeah, exactly, that's right. But oh boy, she's got a depressive personality. She really does not do herself any favours. She's quite difficult and she could be quite rude and quite unpleasant. Sex at an early age. Thank goodness we got the implant on in early, and I think that saved us until she got it out at about 19 and then had a termination, of course. Lots of messiness around school, and ended up at a school who were actually fabulous with it. not like the school, the very conservative religious school where she went, and then she tried selling drugs to an adult who happened to be the pastor.
An undercover agent.
No, she just didn't know it was the pastor. She hadn't been paying attention.
Right.
Yeah, it's not a good move when you're in a conservative Christian school to try and offer the pastors and drugs. Anyway, never mind. I remember her mother and I laughing about that because you could not help but laugh when Mum told me that story. And you know, how she survived all of
Very
those
poor
years.
judgment, very
And you know, it's interesting because part of she is not the brightest tool in the toolbox. She really isn't all.
Was there substance use in pregnancy?
No,
Okay.
definitely not. No, Dad was probably smoking marijuana because that was on the cards a long time, but not Mum. No, Mum's pretty kind of you know, she's not into drugs at all. But yeah, lots and lots of fights with her mother and terrible self-esteem, absolutely terrible. And interestingly, Mum's fights were often around what she looked like. And you know, the fact, and not surprisingly, this young lady and her sister both ended up with body image issues because I think Mum's got some body image issues too that have gone untreated. Mum's repartnered, and if we go to the next slide, yeah, there was at some point she told me that her mother's new partner's son had, exactly what he'd done. I don't know if it was went as far as, it might even have been trying to have sexual intercourse with her while she was still around about 15 or so, I think, from memory. Yeah, and yeah, as I said before, lots of suicidal ideation, lots of impulse control issues, and of course, you know, she ended up getting the diagnosis of borderline personality disorder, which really surprised me, really. And then some pseudo hallucinations, probably more ice related, because by that stage we got onto the ice. So we've got her through year 12, which was a bit of a miracle. And I think the school was fabulous, absolutely fabulous to have tolerated all the stuff that she was into. Very chaotic lifestyle, lots of ice, some really poor judgment. She did manage to bring home a sex offender, which her mother nearly hit the roof when she found out. That scared her a bit, but not as much as I would have liked. And yeah, this one's a real worry. Yeah, and you know, she's tried all kinds of different bits and pieces over the years, but nothing has really particularly worked for her. And she's still using the ice, so it's not an easy one, is it? No. T, we promised you curly cases, and curly cases we have brought you. What do you reckon, Tamara, with this little us?
Oh, look, so I mean, I would go borderline over bipolar with the differential diagnosis between the two. Mostly with that, I'm looking at the fact that was her mood changes in response to an event.
Yes, absolutely.
Now that can be in bipolar, of course, but this looks like it's relationship issues. So it was triggered by a relationship, and immediately after that conflict, you would anticipate that it'd be more likely in the borderline personality spectrum.
Yeah.
Then, well, look, ice does not help. So I'd really be wanting to look at a detox here because you'll get those huge variations in mood. When she was younger, I probably would have gone for more family therapy because it seems like Mum and her sister, and there's obviously a lot of dynamics going on there. That would mean that coming at it from everybody's different angles would be more helpful than individually going off and doing therapy. But at the age that she now is, I would be thinking that, you know, dialectical behaviour therapy, which will teach her impulse control, distress tolerance, communication skills, how to manage conflict, how to recognize emotions, but also how to stop some of what we call self-harm behaviors. So while it's not self-harm per se, as people typically think of it, certainly drug use, you know, all the emotional responses, any behavior that we think is self-harming for your life, we would put down under that category. And I think what would sadden me as my suspicion is that she's all over the place, and therefore I don't know how well she would engage with that kind of treatment. So you'd be wanting to do a lot of that cost benefit around her choices, which dialectical behaviour therapy certainly has a lot of those elements in it, but it's whether she would engage with the full treatment course. So I would probably try for individual one-on-one with someone trained in that style of therapy, so that they could hopefully move her along, but she may well not engage. And then I would try for either way, I would have tried for an inpatient detox as an attempt to just try to clear what's underneath. And if she does in fact have a low IQ, unfortunately that's less predictive of success as well.
That's my gut feeling. I just don't know that she's all that sad. She thinks she is, but yeah, I don't know that she is. Yeah.
So with more of your sort of forensic, where you have a patient and they are making poor choices, and they have that either low IQ or a little bit more forensic, where they don't think their behaviour is wrong and they don't really have a problem with it. We spend a lot of time just on basic, cost benefit, and this is the longer term consequence of your short term choices. And that can be quite successful with that group, but with the ice use, I think that would be less successful.
Yeah. And she's in a peer group where,
I was going to say there's so many other dynamics here, family and reinforcing, and I imagine her rebellion streak is quite.
Oh God. It is. Mind you, the interesting thing is she does respond to limits to some extent. I haven't cracked it completely, but I have basically put my foot down with it fairly firmly on many an occasion, and she will behave herself when you do that. So there is some hope.
The other worry I have is just whether there's trauma in the background.
I wouldn't be too surprised.
Because just mum's, responses to some things are very. So there is some beliefs that borderline personality may have started because your emotions were invalidated very early on. And looking at this, mum seems to have been invalidating later. It makes me think that may well be a pattern. And so, so I would be thinking that a lot of this may actually result off the back of that, in her attempts to get, be able to manage emotions after that. So.
Yeah, I think the other thing with this lass is that she'll do things like not turn up to appointments, not surprisingly. And then, of course, there's a crisis and mum will ring me and beg, plead, and can you please just get her in, and then come in with, well, we're not doing that at the moment because I'm only very part-time, so it's not going to work anymore. But, would turn up with her in crisis and then try and get some sort of, kind of plan around. And it's that combination of invalidation and then kind of stepping in and rescuing her from the consequences of her poor decisions that really resonate about this one.
Yeah, no. So I think people really have to look at those reinforcement schedules, especially between parent and child, about just how what you think you might be doing in the short term, and I understand the crisis-driven nature of things. You really want to help your child, but it actually can result in the fact that they're not experiencing consequences that would make them make a different choice later. So, and it looks like, mum may potentially not be emotionally available.
Yes.
So it may be that this is more when things are a problem for her.
Yes.
Than when they're a problem for her daughter. So and then turning up with that real fix this child. So I always child therapy is one of the frustrations when it has that attitude of here's the child, I'm dropping them off, I'll come back in a few hours and you'll fix them. So
yep. That's about right. Yeah, that's right. Exactly. Yes. I don't know how this one's going to go.
Yeah. Whilst I think, the current presentation, consistent with a borderline type personality and obviously the substance use overlay, I think there's a real risk that there will be diagnostic evolution over time. And there's a few hints about that. So the very early and heavy use of cannabis is quite a strong risk factor for the development of an enduring psychotic illness. So particularly starting from under the age of 15 in terms of cannabis use, starting from under the age of 15. So you have that. You also have the questions surrounding her intellectual represents a risk factor. Trauma itself is a risk factor for the development of enduring psychosis, and also, of course, the amphetamine use. You know, hallucinations and perceptual disturbances, you know, are conceptualized in a few different ways. So, you know, we only see the people who develop psychosis. We don't see the people who don't develop it, you know, in terms of people who use ice. You know, many people do develop psychotic symptoms on ice, but not everyone. And it does beg the question, the people who do, does it reflect an underlying vulnerability? So for someone like this, you know, long-term follow-up to kind of trace the possibility for diagnostic evolution is important. And I think a lot of that is going to be done in primary care.
Yes.
I
can tell you now, yes. Thank you, Julie.
But, you know, without wanting to be too pessimistic, it would not surprise me if she did develop an enduring psychotic disorder or develop psychotic symptoms to the point where people were confused about whether it was primarily drug-driven or having an underlying schizophrenia-type illness. And that can be very difficult to treat when there's comorbidity. People mistakenly escalate doses of antipsychotics in the hope that it will prevent people from becoming psychotic if they're using methamphetamine, but that often doesn't work, and it can often drive the use further because high doses of antipsychotics make people feel horrible and, you know, turn to stimulating you know, substances. So it's a very, very difficult population to treat. Yeah.
Yes. Thank you for those optimistic words.
Yeah.
But it doesn't actually surprise me because I do wonder with this one. Yeah. And unfortunately, it is just having not great effects on the system. Who I will say though, I have gone in to see a really good family therapist.
Oh, great.
Yeah. So there's hope for that one, and it was good because when I write mental health plans, which I'm sure you can imagine, they're usually pretty long. And so the family therapist I sent this one to said to me, when I just looked at her, I thought, oh, I don't know that there's much, but then I read your mental health plan. I went, So I hope that at least we'll get one family member to a better place. Yeah, we'll see. Now we're coming to the end of our time, and I'm going to ask if people have questions or if they would like to ask questions. And do we unmute people? Well, we've got 5 minutes, yes? Yeah. So if people would like to sort of ask any questions or ask to have anything expanded upon, if we've, you know, if there are things that you want discussed or that we've missed, please chuck them in here as we're talking, because otherwise we'll let Julian talk about something that he wants to talk about, and it might not be what you want to hear. Oh, and our battery's running low now. Last time.
Perfect timing.
Yeah. Did anybody ask us a question?
No,
I'm going to let one of you two loose. Who wants a chance to talk about something that's very dear and passionate and close to their heart?
Gosh, I could go on forever. I'll let you go, Julian.
We were just on the subject of cannabis. We were talking about this before we started the talk. I don't think you were here, Jackie. I think that there's, as someone who works with kind of youth and early adulthood, I often see the consequences of adolescent substance use not being addressed much earlier. And that is particularly the case around cannabis. And many people will be aware that there's a very complex dialogue around cannabis worldwide at the moment. And that's led to a lot of confusion about the risks and benefits of cannabis. But unfortunately, what I'm seeing a lot of at the moment is seeing the balance shifting towards cannabis being perceived as a relatively benign or innocuous drug.
Oh God, no.
That's really worrisome to me. The story or the line in the case here about you have to be prepared to accept the consequences and making your own bong. That's actually a really common story.
That's awful.
Particularly cannabis use that starts before the age of 15 is highly neurotoxic. And even if cannabis doesn't appear to have particular cognitive effects or psychiatric effects, it certainly can have behavioural effects, particularly around motivation. And heavy cannabis use can really derail previously flourishing adolescent. And I think that there's a reluctance to discuss issues around cannabis with adolescents. And I've had a number of adolescents who've been genuinely surprised when I've spoken to them about the potential harms of cannabis.
Oh, really?
Yeah, it's quite interesting. So it seems to have shifted quite a bit in recent years. Perceptions around mine, and I think in the primary care setting, it's really important to have those discussions early on with teenagers about cannabis.
It's interesting that, because I mean, it's something that I ask about routinely in teenagers because it's common. It's interesting that people aren't having those discussions. I would have thought as a GP, it's something that you'd expect the GP to sort of talk to the teenager about.
But I think it also reflects the increasingly normative status of cannabis in our society and the fact that parents, we were talking about this before, I made the point that, parents are often using extended family. It's a very embedded part of certain cultures and subgroups.
Yeah, and I think it's certainly the case that in this family, Dad using it did not do this to kid any favours.
And I also think it's the medicinal cannabis, promotions as well as an influence. Now it's on the news, it's on 60 Minutes, and I'm not saying there aren't uses, but I'm just
absolutely.
It then makes it seem very safe.
It does, and that's not doing anyone's any favours, is it? No.
And many adolescents see their mates smoking heavily and without apparent consequences, and there probably is a group of people who don't suffer serious consequences, but there's certainly a subgroup of people for whom it's almost a neurological allergy to a psychiatric allergy to be using cannabis. That's how I frame it to adolescents who appear to have complications.
I like that. I'm going to use that.
Oh, yeah.
Don't put things in your developing brain that aren't going to do it a lot of good.
Yes, absolutely.
Yeah. Well, I don't think we've got any more questions, have we? No. Okay. I think, Mel, are you?
If there's no further questions, that concludes tonight's session. I'd like to thank you to our wonderful presenters, Dr. Jackie O, Ms. Tamara Cabinet, and Dr. Julian Nasty for that fantastic education session. We hope everybody found it valuable and relevant to your practice. Just a reminder that you will be prompted to complete a brief evaluation when you leave this webinar. Please do take the time, as your responses will help us improve future education sessions. SAPMEA also have a number of education sessions coming up, so please sign up to our newsletter called Cognitio or visit our website to see what's on offer. Thank you everybody for your attendance and have a lovely night.
Bye.
Thank you all. Goodbye.